the only way really to run so many people is to have a good structure. I realized that the biggest problem of my company is myself. So today, implant dentistry is very different. It's a disaster. Today, I can tell you that I don't care about the ball.
So digital dentistry, in the end, it's real control or an illusion of control?
Doesn't work.
But sometimes happens.
No,
sometimes
it's
happens.
impossible. Okay, now give me $100.
Hello, everyone, and welcome to our new episode. My name is Olga, and I'm very happy to have with us Dr. Dimitar Filchev, a clinician, a professor, and one of the well-known voices in modern implantology and prosthodontics. Dr. Filchev combines daily clinical practice with academic work and runs a large educational center focused on digital dentistry, implantology, and soft tissue management. Today's conversation will be mostly clinical and aimed at dentists and implantologists, but I'm sure that patients listening will also gain some valuable insight into how modern implant treatment is planned and executed. So, Dr. Filchev, thank you for being with us, and I would like to start with the first question. But before we go into clinical topics, I'd like to start with your journey. How did implantology and prosthodontics become your main professional focus?
Okay, it's a long story. My father used to be prosthodontics, and actually it was by nature that I started to look at him, to follow his advices. And my father was a very, very smart guy, so he was always asking me to give him like $100 when I asked him for advice.
Oh.
So he believed that I need to pay for my education in order to understand and to remember it. So this is why all the time I have paid for the advices of my father. And I was really the most happiest person in the world once that he asked me, "Oh, but Dimitar, how you bond veneers?"
Uh-huh.
And I say, "Okay, now give me $100." So
and now the roles switched.
Exactly. But actually, it came by nature. I'm a person that always try to learn. And I was every time asking my father to come and to see if the crowns that I'm doing are good. So this is why for me was a nice road and way to get on his experience and to try to do the things better.
The best experience. So you combine clinical practice, university work, and a large educational center in Bulgaria. How does each of these roles influence your clinical decision-making?
Actually, it's a very nice combination, and you forgot here to mention that I run also research center.
Okay.
And actually, research, education, and clinic, they match very well. Because we use very often the research to get more knowledge, and this knowledge, after that, we can educate the people based on the knowledge that we get from the research, and then we treat the patient in the best possible way because of the knowledge that we gain. So I think all these things match very well. And for me, it's a really pleasure to be in university. I feel it like my destiny to share my knowledge with the people. And I believe as more better dentists would be in the world globally, as better we would treat the patients, and this will increase dramatically the value of our profession, which I'm fighting for.
Just a few hours ago, during our conference, so you're right now in Tbilisi, we have to say that you're in Georgia, you're holding a very nice conference.
Thank you.
And just a few hours ago, you said that you have like lots of employees. How do they just try to delegate their functions? How the system is working in your educational center and the clinic as well?
We have quite a very well organized structure.
Mm-hmm.
I believe the only way really to run so many people is to have a good structure. So I have a very good friend of mine who is one of the best managers in the world. He used to be a manager of big implant company. And this guy gave me very good advices how exactly to organize the company and how to organize the business. So in my head, everything was a big house.
Mm-hmm.
So once he asked me, okay, please come to me in Switzerland because he's a Swiss. And he gave me a white paper and said, draw the names of all your employees. And I draw them. He said, okay, tell me now who to whom is responding. And that started, and there was a big house. And then he told me, look, now whatever you should do is, first of all, this guy should respond to that guy, this guy should respond to that guy, and then you don't touch. You go only one time per month and discuss with the manager and don't even talk to the employees. This is the way how you delegate to the manager really a lot of rights, and he can be much more effective. So when I came back, I realized that the biggest problem of my company is myself. So this
Too
is
much Dr. Dimitri in the
exactly because I wanted to
bureaucracy.
control everything. I wanted to do the best possible way, and because of that guy, I realized that I should step back. I should leave my managers doing their job, and just if needed to support them with an advice, and then it getting out of the management, I had much more time to dream, to have new ideas, to prepare my lectures, to talk about research, and of course to treat my patients, which is the things that I love most.
Now, I have a question regarding this thing. When the patient is coming to your clinic, visiting your clinic for implant treatment,
Yes.
who is the first he's going to see? Is it a periodontist, prosthodontist?
No. We have a very special workflow. So when the patient is coming to the clinic, first of all, there is a young dentist who is taking all the data. Because today everything is about information. So we need to have together all the information about the patient. We need to do a lot of clinical pictures, videos. We need to do intraoral scanning. We need to do X-ray. So the young dentist is getting all this information, of course, talking to the patient, understanding the problem of the patient. So in this visit, I just come, say hello to the patient. I'm Professor Filchev. I'm very nice to see you. Thank you for choosing our clinic to come. But we need to get all this data. We need to dive inside. We need to understand what is your problem by getting our team members. And once we have a clear treatment plan, we meet the patient on the next visit, and I explain what is the treatment plan.
So this young doctor is kind of a treatment coordinator who will follow the patient from A to Z.
Exactly.
Who knows
So,
everything.
so it's
yes.
like a little bit in the hospitals, the system in the hospitals that everybody has, every patient has a doctor who is responsible for the treatment. And even if it goes through the different departments of our clinic, this doctor is always following the procedures.
That's great. Let's go to treatment planning. What does your mandatory diagnostic protocol look like today before starting implant treatment? You already say that we need to grow scanning, X-rays,
and mock-ups.
Okay.
So today, implant dentistry is very different. In the past, I had friends that tell me, "Oh, Dimitri, you know what? I love to place implants, but when it comes the times to do the crown, it's a disaster." So today we do it on the opposite way. First, we plan the crown, and based on the crown and the prosthetics, we place the implant. So that's the right way to go. And this is why if we do implant planning in the aesthetic area, first we go with aesthetic planning, with the mock-up. We discuss with the patient the future smile design. And then based on that, we start planning how many implants, the position of the implant. And then we look the bone density, quality, and volume. Because bone we can create. Implant we can place. But once we do the wrong positioning of the implant, then it's over.
So yes, prosthetically driven implant dentistry is something that everyone is talking about right now. To what extent do you trust fully digital planning, like CBCT plus intraoral scanning, and where do you see its real limitations?
I believe today intraoral scanners are very, very, very advanced. So we do 100% of our implant treatment, starting from the planning, through the guided surgery, to the final restoration digital. So we rely a lot on the intraoral scanning. If you had asked me this question even 2 years ago, I would say some stages we do analog. Today,
Like
the companies, the technology is advancing a lot. So today we do fully digital every single step.
Well, as far as I know, you have like 7 or 8 iTero scanners.
Absolutely, yes.
So it will be quite helpful, to go digital to make the process a little bit faster. During virtual implant positioning, which parameters are absolutely critical for you?
I told you, for me, most important is the future restoration. So based on the future restoration, we position the implant. But today, the implant prosthetic abutments are a little bit more flexible. We have the dynamic driver that even if it's not perfectly planned, we can create a screw retain crown with a little bit angulation up to 15-20 degree, which means that we can be a little bit more flexible. And still, for us, the most important part is to plan very well prosthetically. And then from that, we go up to the bone quantity and quality.
We will talk about prosthetics, we will talk about soft tissue management, but first I would like to start with some basics and some popular topic, which is immediate placement or delayed placement. What do you think? Which factors are decisive for you when choosing between them? Implant placement, immediate placement, or delayed placement?
If I have the option to do immediate placement, I always do it. Because then you follow the natural mechanism of the body that it creates bone. So of course it's something very good. But there is quite few limitations. So you shouldn't have acute infection. You shouldn't have acute periodontitis. The reason for losing the tooth, you don't need to have acute endodontic infection. So. But let's say if the tooth is in the proper conditions, so no any acute inflammation process, endodontic or periodontic, then it will be my first option, especially if we talk for the aesthetic area. In the aesthetic area, I always try to go immediate. Yes. In the distal, today with the socket seal technique, which I definitely love, we have very, very good results with only one step, shaping the tissues in a very good way. So if we have the chance to be on the safe side by placing an implant without any infection, I would definitely go for immediate placement.
Speaking about aesthetic zone, what is more important for you? Ideal implant positioning or predictable soft tissue control?
It's connected. The ideal implant positioning brings nice soft tissue contour. If you place the implant, let's say, more angulated, then you lose the volume of the soft tissue. Then you lose the soft tissue profile. So actually, the perfect positioning should be based on the soft tissue contour and prosthetic restoration, and that's connected. I wouldn't divide them.
What are the minimum primary stability criteria you personally accept for immediate loading?
For immediate loading, if we speak about ICQ, I go at least 65 ICQ.
65.
And speaking about Newton centimeter, my red line is 45.
Okay. Do you use this ICQ Osstell, for example,
Osstell,
in each of your...
Yes.
Okay.
I do a lot of research. And I don't know what kind of research I'm going to do sometimes. This is why I collect all the data for all my implants. Having all the protocol of X-rays, photographic pictures, and collecting the stability measurements, filling all the documents. And then we do a lot of data. I have I have 6 PhD students which finished their PhD work. I have 3 more running it now. And I have 2 more ideas. So in order to be able to support my PhD students, we do a lot of research. For me, research is one of the biggest advantage that we have. You know, I have a very good friend from Lebanon, nice guy. And he told me once, you know, Mitko, if you want to be good position, you should create a good research team. And I followed the advices of the smart people. So I followed his advice and I created a good research team. And you know, today this is, first of all, bringing me a lot of professional pleasure. And second, it's really a big power to have the knowledge of, and to be able to answer the question, why you do this technique based on your own experience and on your own research data, which is great.
Yeah, sure, it is great. Okay, let's speak a little bit about guided bone regeneration. Do you use modified GBR protocols and in your practice? And if so, how do they differ from classical approaches?
I'm more soft tissue fan. So, it's a conversation that we can talk about
Hours.
until Sunday night
Yeah.
and fight if it's better to have more soft tissue or to have more hard tissue. But today,
It's connected.
yes and no.
Mhm.
In the past, we were fighting to get more bone.
Mhm.
Today, I can tell you that I don't care about the bone. I want to have a tissue. Want to have nice thick tissue, and I don't care if this is epithelium, junction epithelium, connective tissue, or bone. And I feel much more safe if I have very thick soft tissue than if I have a very good bone. Because in my 25 years of implant experience, I saw very, very well placed implants in a lot of bone, and the bone, like for 1 year, melts. But if you have a strong soft tissue with a nice connection to the prosthetics, then you are safe. This is why I believe much more in the soft tissue augmentation than to the guided bone regeneration. So today, I do very, very rare guided bone regeneration. We do it in the posterior mandible. Let's say if you have very thin um, ridge, or we do it when we do the sinus elevation, of course. I do this very often as a procedure. But some very, very complicated techniques, I personally don't do. We have one very good surgeon who is coming in the office. Let's say if we have like very, very resolved bone who is doing this, and he's doing like all different techniques, like quarry techniques. He had invented also zirconia membrane that he's using, so different kind of stuff. But this is something that he's doing. Me personally, I prefer always when I can to manage the case with the soft tissue.
So soft tissue management is your like expertise area, key expertise
Yes.
area. Then I would like to ask you, what soft tissue management mistakes do you most frequently observe among other implantologists? Lots, lots of them.
It's about education.
Mm.
There is a genius guy. I believe he's like Messi in periodontics and in the dentistry today, Giovanni Zucchelli. Giovanni Zucchelli, they claim that he's a very talented guy and that his technique works only in his hands. But fortunately, he started to be a very good teacher and to try to educate more people. And I was very lucky to be among his students to be able to perform perfectly his technique. But it's a technique that works very nice, but after proper education. So many people think that if they look a video on Instagram or Facebook or just even Zucchini channel, they can perform it well. Doesn't work. So in order to perform such technique like this, even if we speak something even more simple, like prepping the teeth, like with the BOPT procedure that Ignacio Loy had invented, even for that, for all these small techniques and details, you need to have the proper education. So today, unfortunately, on Facebook, on Instagram, I call them Facebook and Instagram University, uh, people see only what the person on Instagram want them to see, but we don't know if this is real, if he has only one success case and 100 lost. And the people look at it and try to perform it, and this is how they do a lot of mistakes. So first of all, they do mistakes by performing the soft tissue surgery, but they do much bigger mistakes by the very bad prosthetic construction, because even if you perform the best soft tissue surgery, if you don't have the right prosthetic restoration who can support it, you lose it.
Lose it. I see. Um, how do you personally approach the creation of a stable emergency profile around implants? How do you create it?
Two ways. I mean, uh, it's one way, but two stages. First of all, soft tissue augmentation. We do soft tissue augmentation of most of our cases. Second, long-term provisional restoration. For every single implant that I place, I go for at least 2, 3, 4 months provisional restoration.
Mhm.
So provisional restorations, they're very, very underestimated. But I can tell you, we do a lot of research. So we did a split mouth study on half of the mouth only with by healing colors and final restorations, the other half provisional restorations, and then final restorations. The results were significantly worse for the protocol healing, final restoration. So with the provisional restoration, we have two main advantages. First of all, we can predictably maintain the soft tissue and see exactly what is the level, because the PMMA is a little bit dirty material, and like a dirty material, it gets the soft tissue attached on it. Dirty, I mean it has pores inside. If you do a provisional restoration from zirconia, it will not work. But with the PMMA, it works. So then you see a very nice attached profile, and you can manage it with the provisional restorations. Let's say if you can add a little bit more composite or PMMA and it's growing after it, or you can cut a little bit more and it's following it. So this is how a little bit through prosthetics you can guide the soft tissue. And then the other big advantage is the loading, the functional loading, which is progressive. So you don't load the implant immediately with the zirconia restoration, which is stress for the bone, but you do progressive loading, which is another great advantage.
Step by step.
Yeah.
So the first step was the soft tissue augmentation. May I ask you, do you use dermal membranes or you prefer to use auto soft tissue?
We do connective tissue from the palate mostly,
Mhm.
but I used to use a lot of dermal products
As well. So
as well.
membranes work.
Yes,
They
yes,
can
but
maintain
from
soft
my
tissue.
human resources.
Ah, okay, I see. No, I'm asking about the xenografts
I
or something
prefer
to use auto.
allografts.
I see. I see.
prefer allografts or autografts.
I can see. In which clinical situations do you prefer to manage soft tissue before implant placement and when after?
Always when I have a lack of soft tissue, we prefer to have soft tissue management before implant placement. Of course, sometimes if it is manageable, we can do it in the same visit, but depends on what do we want. But let's say if you want to make a bone graft or we need more volume and we don't have enough soft tissue, first stage is to get more soft tissue. Second stage is to open to the bone graft, because you need to cover that bone graft. And for that you need the proper volume of soft tissue. So it depends on the situation. We
But
can do
usually,
both.
but usually you do before the implant
Usually
placement.
I do together.
Together,
Today
yeah.
we try to do always in the same step.
Sure.
But as your questions was, are you doing it? I do it sometimes if I need it. But my protocol normally is everything on one step. So we do mucogingival surgery, we place the implant, and we place the soft tissue graft in one single stage.
Mm. In your opinion, can excellent prosthetics compensate for poor soft tissue management?
There is not excellent prosthetics without a proper soft tissue management.
I knew it. I knew it. You have already said this about like 5 minutes ago. But sometimes happens.
No,
Sometimes
it's
happens.
impossible.
It's impossible.
Today, I believe, I'm a professor in prosthodontics, and I graduated the master program of periodontology by Giovanni Zocchelli. I graduated the master program of Marcus Kürzer and Otto Zur. I was in all the courses of Cortellini and Tonetti. So for me, today, a contemporary prosthodontist needs to have a very good knowledge on the processes of the biology in the periodontium.
It's about education. Education, practice, understanding the mistakes that you made, and learning. Let's talk a little bit about abutments. What do you think? Custom abutments vs stock abutments. Where do you draw the line in your decision making?
This would be a very good question 2 years ago.
Something has changed.
2 years ago, even I had one of my PhD students did a PhD work by setting it the right protocol, and she did a lot of measurements between stock abutments and milled abutments and tie bases. Trying to make a recipe for the best abutment. I would say today the digital protocol changed so many things, and today with most of the companies have so well developed tie bases which are in the libraries that it doesn't make sense to make anything else.
Mm.
I mean, tie bases today with different heights, with concave profile, with dynamic driver. It's a golden standard that makes everything much, much easier and much more predictable. So this is why today we almost don't use any other abutments anymore.
What about the subcrestal placement of the implants? If it's quite like 2 millimeters below the bone, how do you use the tie bases?
You can use connect abutment.
Sure, exactly. Connect abutment, it's very nice, very nice.
Exactly. Or
thing.
you can use a system that is on the bone level, not below the bone level. So, today we have so many different kinds of implants and so many different concepts that you can easily choose the one that is fitting you perfectly. But I would say the multi-unit doesn't make difference if it is connect or some other. Is something very unique as a way to go, because you create from the bone level implant tissue level implant.
Exactly.
And then it's
Switching.
you manage everything upon the tissue level. So I love the multi units. I use them since more than 20 years, even for single restorations.
Yeah, it's great. No, to connect the system one time abutment
Exactly.
is very, very nice one.
Exactly. But in general, if you don't have it, tie base works perfect.
Which steps of the digital workflow must often become sources of clinical errors in prosthetics?
It's so well already integrated that unless you have you follow the right protocols, I don't think you can make a mistake. There could be some small mistakes. Like once I received from my Swiss technician, I did a scan for 1.4 and I received a crown for 2.4.
Oh,
Somehow he swapped the picture. I don't know how, and he sent me the crown for the other side. But it's one time in all my career that happened. So in general, if you follow the right protocols, and we have a very, very clear protocol. We do a 3 scanning protocol. We scan the profile, we scan the provisional restoration, we scan the scan body. So like this, there is no mistake.
so it doesn't correspond, digital workflow doesn't correspond to clinical errors as usual.
No.
Okay.
This is why I believe so much in it, because it makes the work of all of us very predictable. In the past, you should work with a fancy technician in order to get a good quality of your work. Today, every normal lab following the digital strategy can create a very, very good average crown. Okay, maybe it's not the best color and ceramic effects inside, but let's say if you do a lower 6, who cares?
You just said that 2 years ago, probably there would be another answer to my question. It means that during last 2 years, we can see that something is changing in implant dentistry. So do you have any internal clinical standard that you never change, regardless of trends or new technologies?
My motto is that the planet is not stable and always change. So whoever don't change will not survive.
So we have to move, learn, and move.
Absolutely. So
Like a planet moves.
if the technology is progressing, we shouldn't stop.
Mhm. So the protocols are also changing.
Of course. If we have 2 years ago, I had a clear protocol based on the PhD work of my PhD students. I do milled abutment always on the posterior. I do factory abutment with zirconia, individual coping on top for the aesthetic restoration, and then lithium disilicate. So I did the sandwich technique in these cases. So everything this is in the past. I had perfect results with that technology, but why? Today, I just scan my 3 scan technique. Then in the library, the technician is choosing the perfect tie base, fitting a zirconia crown on it, and I receive the ready crown and I fix it in one single appointment. So why not to change it if it works better, faster? The patient is happy, everybody's happy.
So you're not a person of, I would say, conservative views. You're trying to adapt to new trends and new technologies. And it means that your clinical practice is full of digital planning, which is great, which is really great. But
We are one of the most digitalized practice in the world. And I believe that I'm a person who not only use and follow the newest strategies, but also create them. This is why I'm part of the team who created the first robot prepping teeth, and this is why I'm part of the team who create AI for dental industry, and we use AI in every single stage.
how do you use AI in your everyday practice? Tell us. It's interesting.
Sure. Yes. Planning, diagnostic. We have every AI and we have AI on every single step when we do, starting from the internal scanning, where we have now in the Lumina AI integrated in every stage. Then on the Smile Tech, the Smile video is based on AI. Then when I go to my software for implant planning, it also has an AI who supports the matching, and then it chooses for me the best implant, and then actually it makes the steps faster. And then I want to go to my Invisalign, and then I have my personal AI assistant who knows my preferences, and he gets me much better prognosis of my treatment compared to the technicians. So every single step today, the technology is integrating AI, and I'm personally trying to support as more as possible because this is the future. This is making my life much easier. This is making the life of my colleagues much easier, and we can do much more using the technology.
I love to hear that because usually it's quite tough to go from, from classic protocols to some new technologies. But you're the person, as you already said, you also create you. But all those creations that you are doing based on the research center you have, and this is very good. It's a good luck
This is why I told you that all these things match very well with each other.
with each other. Yeah. But let me ask you one question. Let me ask you this question. Have
Ask
you
me.
ever had a case where the digital plan had to be completely revised during surgery?
Of course.
Mm.
You know, the life is whatever is happening to us until we do the planning. Of course, I mean, sometimes on the CBCT, the bone, let's say, looks very nice, but when you open, you see it's very soft and doesn't look so good. So you need to change the plan. There is, I mean, today still the CBCT, I would say, it's not so that perfect quality that can give you the perfect information to plan everything accordingly. And then also, let's say we cannot do the everyday CBCT to the patient. So let's say we extracted the tooth like 2 months ago. I don't do another CBCT, and then suddenly something changed on a bad way or a good way. But sometimes things change very fast, and we don't know it. So
It's very important to have a very good manual skills.
Exactly.
You have said that despite the fact that you can see on the X-ray, on the CBCT, that the bone is very nice, but then you open the flap and you start drilling and you see that the bone is quite soft. So it's important. It's very important to have the education, the practice we are speaking about. So, and I would like to ask you the next question about some manual skills. Which clinical skill do you think is currently most underestimated among implantologists? Maybe some of them are trying to rely only on digital tools.
which is a big mistake. Not because I don't believe in the digital tools. I mean, for implant placement, I speak. But it's much better to see and to feel because I saw a lot of things in my daily practice, not only by myself, but complications of another dentist. Because for me, being as one of the, let's say, most well-known implantologists in Bulgaria, I get a lot of cases with complications from other dentists. And I see that many people who rely absolutely only on the surgical guides and they don't have the manuality to react on a complication can fail. This is why we come back to the education. So in order to place good implants, you should be well educated. It looks very easy. Scan, make the guide, place through the hole with the drill, and then place through this same hole the implant, and it's done. And so everybody who we took from the street could do it theoretically because the technology looks very easy. But sometimes the bone is not the same quality, sometimes there is infection there, sometimes. And then you need to have the knowledge how to react. If you don't have this knowledge, you fail.
I see. Just a quick question. If you say that after drilling the jaw, if you see that there is no blood, it's D1 bone type, what do? Do you place the implant or you wait for several weeks?
No, I place the implant.
Oh, really?
Yes.
That's interesting.
Yes. But
Despite the fact that there is no blood?
Yes. But I do over drilling.
Uh-huh. What do you mean by over drilling?
Let's say if I have an implant 4.5, I drill 5.
I see.
And I keep only for the apex. So I get the stability only in the of the implant only in the apex. It's enough to get quite normal stability. But then there is a hole around and the bone starts bleeding, obviously. And I get a new bone formation around my implant.
I can see. Speaking about implants, hydrophilic implants or conventional implant surface?
Look, the implant surfaces are developing a lot today. So I would say on both sides, we can have a very good, for instances, of successful implants. Still, the newest editions of implants needs time to prove their long-term stability. Because we all know that what looks perfect today or in 5 years maybe will not look perfect in 10 years. So for implant surfaces, I would say I'm a little bit more conservative. It's not that I wouldn't change, but I would like to see the proof, the scientific proof that it works after a few years. Because if I do it in the university on patients who agree to be part of a study, I can do everything. But on my private patients, feeling me myself responsible that I choose for them the right material, I would like to place an implant who is really safe and proof during the years.
I see. So again, it's about research. It's about research, about some facts and experience, even if you're speaking about implant companies as well.
Exactly.
So one stage or two stage surgery?
Of course, one stage is better, but I do very often 2 stages.
So
I
more often.
tell you why. Because in Bulgaria, most of the people smoke.
In Georgia as well.
Yes, and I'm a little bit concerned doing 1 stage surgery on smokers.
Because of the blood.
Because of the blood, because nicotine is making decreasing the blood count, and also sometimes they don't have so good oral hygiene based on the cigarettes and nicotine and all this stuff. So I'm a little bit more cautious. I have my bad experience with the smokers in terms of open surgeries, immediate loading and this stuff. So with smokers, I'm very conservative. This is why I tell to my patient, if you decide to smoke, it's okay, but you get bonus 2 surgeries.
Do you give your patients some antibiotics after the implant treatment?
Before.
Before?
Yes, 1 day before, always.
So digital dentistry, in the end, it's real control or an illusion of control?
It's a real illusion.
It's real illusion. Okay, nice. Very nice. What would you say? So you have an educational center, you have lots of employees, so you are in contact with many, many young implantologists. What common mistakes do they make when planning and treating the patients?
Biggest mistake when
Yes.
you're young is being too much self-confidence. It's the biggest mistake. Because I see very a lot of young dentists doing like crazy full mouth restorations, surgeries that they're not really capable to perform the complications. If everything works well, it's okay. But if there is happening complication, then it's a disaster. And as more you know, as more you're cautious. So if you don't know too much, you're very brave. Let's do this and that. So this is the biggest problem of the young people. And this is normal. But the technology is supporting them to be more brave because they have some tools in their hands that we never dreamed for. This is why I believe the golden amalgam is the experience of the old people, or the experienced people, let's say not old people, the experienced people, and the technology that is the power of the young people. This is why I believe in the teamwork. In my team, we work together with young people that have very well technology and they use my experience. So like this we match and we do proper dentistry.
What do you think about zero bone loss conception? Do you believe in it? Is there any possibility to get this result? Or just to be closer to this result?
I'll be honest with you. I believe not in the zero bone loss concept. I believe on the bone gain concept. So I mean that around many of my implants, and you'll see in my lecture later, we gain bone with the years. So we don't lose bone, we gain bone. And it's, again, a question of proper planning, soft tissue augmentation, and occlusion. Mm-hmm. There was a very good French professor who was coming to Sophie Dental meeting, the conference that we organize. And this guy was showing me 20 years old cases with bone growth. And he was a very good occlusion dentist. Only by maintaining and managing the occlusion, he was gaining bone. So there are many factors. Speaking about the zero bone loss concept, you focus only on the crestal, platform switch, and this kind of stuff around the bone. But it's so many things: soft tissue, profile of the prosthetics, occlusion. Then if you do everything properly, you can gain bone and don't lose bone. So me, personally, I'm very happy that I'm trained as a good prosthodontist. And like this, I understand occlusion. And this is why we have a very, very good long-term results on our implants with a bone gain.
Do you use any devices which help to treat the bad occlusion, the wrong occlusion? Are there any devices?
Of course.
Modjaw or something like that? Is it connected to...
You mean devices as scanners or modules?
Yeah, something like that.
Yes, everything.
Is it effective?
Everything what can bring you to better diagnostics can support you for sure. Modjaw, and I believe all the scanners in the future is going to have the same things that Modjaw is doing.
That's interesting.
This is for sure. I mean, some of the companies are very close
to integrate it.
Integrated, yes, already. So more or less, for sure, this will help.
Are all implants that are being placed by you placed subcrestally?
No.
So you're not the person who's saying that it's always good to place an implant subcrestally?
It depends on the implant. I place very different kind of implants.
Bone level?
I place so tissue level implants. I love tissue level implants. For the posterior mandible, it's perfect because it's one piece, it goes up to the tissue level, and I have so many 20-year-old cases that look amazing. So sometimes I still use it. Or sometimes I can use an implant with a polish 1 millimeter that can give me polish neck, that give me the freedom to play with it. Sometimes I use an implant that I need to go below. So it depends on the clinical situation, occlusion, bone density, so many factors. So I don't believe there is an implant with a perfect design for all the cases. This is why I have a portfolio with 10 implant designs and I use the proper one for the proper case.
Yeah, I asked you this question because now more and more doctors and speakers and key opinion leaders, or like very popular voices in our industry, are saying that, you're like in your comfort zone, in a safe zone when you place implant subcrestally, like 1 millimeter or something like that. but you are saying that it depends on clinical situation, right?
Yes.
Okay, great. So we have to run right now. We have to go and to continue our congress, our conference. And this is why I would like to ask you a few last questions. It will be kind of a blitz questions. What's your favorite movie or movie genre?
My favorite movie is Forrest Gump.
I love it. I
Yes.
love it. I love it. It's one of the best
It's one of the best, yes.
because he's one of the best actors.
Exactly.
I mean, he's
amazing.
my
He's
favorite one.
Me too.
Each movie is like crazy, but Forrest Gump is something
Yes.
no one will, I would say, not everyone will understand how deep is this movie, but I don't know, actor is very great. I'm sorry. Coffee or tea?
Absolutely short Italian espresso.
Aha, okay, now I know. What do you enjoy most? Your favorite food?
I like different kinds, but of course Italian food is my favorite.
Okay, Italian food is good. Vacation style, active or relaxed?
What do you think?
Active.
Of course. You cannot see me relaxed.
Okay, if you had not become a dentist, what profession would you have chosen?
Maybe I would be a billionaire.
Billionaire. Do you think it's a profession? It's nice.
No, all my friends are billionaires.
Oh.
Just because they went into the IT industry,
I see.
and in Bulgaria it was very profitable.
Really?
So yes, they sold their companies and they made a lot of good things. By the way, so because I was part of a group that was going inside the IT business, I would be part of these guys, for sure. But today, I would say I'm very, 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 very happy being a dentist. It's my really great feeling to be to run this work, and I feel it. I feel very motivated. Being even more than 50 years old, I still have a lot of horizons and a lot of things to do in this profession.
Oh, I love to hear that.
Yes.
But what truly inspires you out of dentistry?
Sports,
Which sports?
sailing, tennis, football.
Oh, big tennis?
Yeah, tennis court.
Okay, Federer, Nadal, or Djokovic?
Djokovic.
Oh, come on, no, Federer.
Yeah, well, I'm from the Balkans.
Okay. Yes, okay. So the last question. The last question is about hobby. You said that you're, running business, clinic, educational center, research center, some other stuff you are doing in your daily life. But what's your hobby? How do you relax?
Sport, traveling, enjoying friends. I love to party. I love to go out with some friends and to talk about different things. So
That's good. It's good. Thank you so much for your time.
thank you so
Thank
much.
you.